Nick Majerison here. Welcome to Top Med Talk. Today's Top Med Talk is called What Do You Value? The first roundtable discussion hosted by Desiree Chappell and featuring Monty Mythen. That's what you're about to hear. It was recorded on February on the first night of the Interdisciplinary Conference on Orthopedic Value-Based Care. It's the fourth segment of the conversation, and it's between Desiree, Monty, and their two guests, Shawna Butler of the Singularity University in Exponential Medicine, and Jennifer Brandon of the Hoag Orthopedic Institute in Irvine, California. Here, Monty speaks from a transatlantic perspective about the need in value-based care to know your outcomes. Have a listen.
Top Med Talk.
Monty, I was thinking about you and what you've done in the UK as far as reducing variability of providers in care with enhanced recovery and perioperative medicine. Can you speak to that just a little bit?
Sure. So, hi everyone. I'm Monty Mythen. I'm from London in England, so I work in the National Health Service. But my last job before I went back to the UK was I was on faculty at Duke in North Carolina, so I think I've got quite a transatlantic perspective, and I've visited almost every state in the USA in the last 5 years. So I think your question particularly related to variation and compliance. Well, I mean, that's the big challenge. I think a lot of people fail to understand why we have so many different versions of what we believe to be the right thing to do, and they can't all be the right thing to do. I mean, Shawna was talking about exactly the right point here, is that usually people don't actually know their outcomes. Let's take the joint, for example, because Jen's here from that perspective. They think they put the joint in well, and therefore the pain must have gone away. Whereas I don't know if you know for your elderly patients in your practice, Jen, how many people get the improvement they were hoping for.
Back to their baseline. Or just inactivity. They wanted to play golf.
They were told it was going to get better.
Yeah.
Do your surgeons know? So nationally in the UK we have to publish that, patient-reported outcomes, and
Yes.
I think we were shocked when they first came out. 40% of patients who have a knee replacement say they are now worse than they were before. Mm-hmm. So they tell us all about the 60% that feel better, but what about the 40%? They haven't gone back to baseline. They're worse.
They're worse.
Yeah. You guys do enhanced recovery, Jen, at your facility. And is that something that you guys talk about preoperatively?
I don't know that we discuss it from an outcome standpoint, but we talk about it from an expectation standpoint. Like, the expectation is that you will get up in a certain amount of time after surgery. For our hip patients, we expect that you'll go home that same day as long as you're feeling okay. In the hospital, we do know our outcomes, but we know things like infection rates.
Length of stay.
And readmissions. But it's a good point that we don't get much feedback on our end about the patient's
Jen,
outcome.
aren't they things those are all things that matter to us, aren't they?
Correct.
Yeah.
But not necessarily to the patient. Well, if you're going to shop around for a facility, you are going to look at infection rates and readmission rates, and you're going to look at your surgeon's outcomes. And, we are upfront with those kind of things, but I don't know that they're necessarily upfront with the percentage of patients that felt like they got what they wanted out of the surgery.
Or how many people have got a nice new knee, but now they've got acute kidney injury, they've had an MI, they've had a stroke.
Right. And I'm not so sure that some of the data that you're collecting is really an outcome. So from the standpoint of we look at infection rates and readmissions, those are indicators of how well are we doing with the process, as opposed to an outcome, which is, am I pain-free or less pain? Am I able to play golf? And then we don't necessarily have that follow-up to look at them 1 month, 2 months, a year. That's what value is. Any money that you spend and you don't get a better life, it doesn't matter how perfect the care was. It's one of those, the surgery was a success, but the patient died. So we performed everything and we had every metric that we got right. But the outcome that we achieved was not, it fell below what we were looking for. But too many times we're not mapping what the patient's value and preference is. They may walk better, but the amount of money that it has cost them, or the opportunity cost, they look at that and like, if I had understood that earlier, I don't know that I would have made this decision for this type of a treatment.
Mm-hmm. The unfortunate thing with our system, though, is that Medicare doesn't reimburse based on whether the patient walked down the aisle at their daughter's wedding. They reimburse by, was the hospital clean? Was it quiet? What are your readmission rates? And things like that. So, it's a fault of the system that we have to pay attention in the hospital setting to certain things that aren't necessarily as valuable to the patient.
And I don't think any of the systems reimburse for helping somebody decide that surgery is not going to necessarily improve them. All of our systems reimburse for doing the surgery, for getting the joint in. They don't reimburse for saying, actually, on balance, you're probably better off not having. The knee might still hurt, but you're less likely to have the stroke or the heart attack or... Long silence.
No, the interesting word there to me is reimburse.
Yeah.
So we are practicing reimbursement-based medicine, not value-based medicine, not outcomes-based medicine. We will do what we are incentivized to do. Part of that is that we're in this really interesting place to say there might be better ways for us to be measuring this and again, it's not reimbursing, because what that says is that somebody else is paying for this service. We're not actually looking at ownership, and we're not purchasing based on the value of something that we're getting. So when you think about, I want to be able to be pain-free, and I want to be able to go out and walk my dog. What is it going to cost me, and how much am I willing to spend to make that happen? So if we change that language and that dynamic, and everybody does, they look at it like, well, will the insurance company pay for it? That's not always the best indicator of whether or not you should have something done. So I think we're in a unique position to actually change that conversation and to use a different vocabulary so that people truly can have value-based care. So part of that is, what is value? What do you value? And what are you willing to spend? And what risk are you willing to take to have that outcome? That was why the long silence was, when I hear that word reimburse, I'm like, oh, that's the worst way to start evaluating whether you're not going to get value.
But I do think that that's why you look at an enhanced recovery program, and we're doing things that are not reimbursable, they're not billable. For example, our class, that's the therapist isn't billing it, it hits our productivity, but we do it because it's the best thing for the patient and the caregiver, because it does alleviate their anxiety, gives them a chance to practice. If we integrate some type of tele-rehab into our post-acute phase, which we're looking at, that's something the hospital's going to take on because it's the best thing for the patient. So I think we do look at these things, it's just an unfortunate way that the system is set up.
Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com. and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.